सकते हैं ना सर वहाँ पे। हाँ मतलब इट इज वेरी डिफिकल्ट। ओके
फेस तो आपसे शायद चेंज हो जाएगा।
नहीं सर कोई नहीं, मैं चाहिए ऐसे ऐसे कर रही हूँ। नहीं नहीं मैं खड़े होकर पढ़ा नहीं, बैठ के पढ़ा नहीं।
तो फेस साइड चेंज
नहीं मैं कर
ठीक है।
अरे मुझे वो स्पेस आपसे पता नहीं चला। Good morning, sir. Good morning, students. So today our topic is antisocial personality disorder. Actually, in the beginning, I had thought that I would give this cluster B personality disorder in one class, but there are more than 100 of slides. So I decided to divide it so that at least we can do justice to the topic. So the first question that arises is, we are psychiatrists, okay? We don't really delve into psychotherapy, or we are not much into, the dynamic part or the psychodynamic part. I mean, we read it in theory, but in practical, we are mostly into pharmacotherapy. So the question arises to, why is this topic important? Why should we learn about personality disorders? Anybody would like to say why you should learn? पता मेरे क्लास थोड़े मैं पूछूंगी बीच बीच में, मुझे आप लोग सो जाते हो क्या? कुछ भी मतलब इट्स वेरी इजी, ऐसा कुछ मैंने बहुत पूछा कि हमें क्यों पढ़ना चाहिए पर्सनालिटी डिसऑर्डर, राइट? ओके पक्का होने के लिए कि इट इज नॉट पीडी है, साइकोसिस। ओके यस, सम एक्सट्रीम forms of personality disorder can look like psychosis. There are many interesting medical legal aspects also to this, and so treatment. Okay, actually all now the multi-axis diagnosis is not there in DSM, लेकिन आपको पता है कि axis 2 is personality disorder and axis 1 is other disorders, जो normally हम psychiatric diagnosis देते हैं. तो everything that we see within axis 1, the symptoms that we see in axis 1, चाहे वो depression हो, चाहे वो psychosis हो, चाहे वो anxiety हो, it is influenced by axis 2. ऐसा actually वो multi-axis diagnosis उठा दिया, एक तरह से अच्छा भी हुआ कि ऐसा कुछ axis 1 और axis 2 कुछ compartment नहीं है water type कि axis 1 अलग सा है और axis 2 अलग सा है ना? So axis 1 is always influenced by axis 2. We see many like schizophrenia patients will not have the same kind of symptoms. Also, anxiety patients will not have the same kind of symptoms. Also, the same situation like PTSD, for example. PTSD हर इंसान को जिसको वो traumatic situation होता है, हर किसी को PTSD नहीं है, right? Some people go through lot of problems in life, but they never develop any axis 1 disorder. There's some people even in minor things, कुछ minor things होते हैं तो they burst like volcano. So why? The answer lies in because of their personality. जी सर. थैंक यू सर. हाँ हुआ. So the importance is, the person in the clinician must treat the person in the patient. Okay, the patient is not the diagnosis. We must understand the basic, where the patient is coming from, right? So we have to work with the patient within the context of the particular personality, organization, and style. Also, the therapy that we give, okay, every patient will not have the same acceptance. Okay, the paranoid person may be very suspicious. Okay, the narcissistic person may think इस doctor को क्या आता है. Okay, the antisocial person may be trying to manipulate you and giving them more benefits. It's all good enough. Okay, so we have to understand the context, and of course there is the benefit of understanding the whole patient and not simply these are symptoms. So अगर हम patient का personality समझ पा रहे हैं, then our therapy will be better suited or better tailored, okay, to the patient's needs. So that is the importance of personality disorder in psychiatry. So this is the basic, definition we can say. So these are deeply ingrained and pathological patterns of thought, feeling, and behavior that can be traced back to adolescence and early adulthood. I think this is something that we all know, but it is also important. Personality disorders onset is in late adolescence or early adulthood. Personality disorder does not, suddenly start at say 30s or 40s. Then obviously it is not personality disorder. Also, second thing I would like to say, फिर personality disorder में we take the cutoff of 18 years, okay? But that does not mean कि 17 years पे there is no symptom, okay? ऐसा नहीं कि बहुत अच्छा था, बिल्कुल ठीक था, 18 जब 18th बर्थडे होगा सडनली वो एंटीसोशल हो गया, ऐसा तो होता नहीं है. So some idea of personality you will have by 5 to 6 years of age. Okay, there is some idea. There are even papers on this that we can judge your temperament both ways. Okay, but we do not give a diagnosis. We give a diagnosis only when the patient crosses 18 years of age. So it creates subjective distress or experience functional impairment. Personality disorder, many personality disorders are ego-symptomic. मतलब patient को कुछ खुद को कोई distress नहीं हो रहा है, ठीक है? So that's why there is functional impairment because of that. And some personality disorders, they are not ego-symptomic, so patient is in much distress, especially in cluster C kind of personality disorders. But mostly the pathology is out of their awareness, okay? Mostly, but it doesn't mean that always patient is very innocent and do not know, okay? And there is obviously no quick cures for this. So the overview of treatment is mostly the treatment of choice is always psychotherapy, okay? Cognitive, behavioral, or interpersonal or psychodynamic perspectives in treating these disorders. Psychotherapy is different for different kind of personality disorders. मैं खाली general overview दे रही, then when I'll go to individual PTs, I'll discuss individual treatment. So mostly psychotherapy is treatment of choice, first line of treatment. Along with pharmacotherapy, we'll go to that. But what kind of psychotherapy? Different personality disorders will have different kind of. Most commonly used is CBT, cognitive behavioral therapy. Okay, interpersonal therapy and psychodynamic therapy. So we'll go into details when you go into individual personality disorders. Overview of CBT is you have to identify the irrational beliefs. Okay, you have to clarify and you have to facilitate the expression of those beliefs, and you have to reinforce healthy behaviors and choices made by the patient. Also, the psychotherapy is a long-going process. Okay, this is not a one session or two session kind of therapy. People go into therapy for years. Then they have some level of functionally they are okay, or they have some remission of symptoms. So this is a long term treatment. Okay, you have to identify what are the thought patterns, what are the beliefs, why did they behave the way they behave, then make them realize that what they are doing, what kind of defense mechanisms they're using. Okay, and this is not in a confrontational manner, obviously, and ये एक दो session में नहीं होता. This is a long term treatment. Okay. Okay. Interpersonal therapy is understanding and managing transference. What is transference? Final years. Transference is from patient to doctor, and counter transference is how the patient makes us feel. Okay. Especially in personality, cluster B personality, there will be a lot of transference and counter transference, and you have to be aware of that. Okay. If we submit to the counter transference, फिर बहुत गड़बड़ हो जाता है. So the firm boundaries should be maintained with everybody, but especially with cluster B, firm boundaries should be there, and we should be very much psychological aware of our counter transference, and we have to manage the patient's transference. Okay, this becomes more important in borderline. We'll talk in later. Okay, and identify and work for mechanisms of defense. This is very important. Actually, personality disorder. Why is it a disorder? Because their defense mechanisms are not mature. अगर underline बोले तो their defense mechanisms are not mature. So the crux of personality disorders treatment is to identify the defense mechanisms which are obviously not mature. They may be immature or psychotic, and make the patient aware of defense mechanisms, maladaptive defense mechanisms. So that is the crux. Okay. You have to balance the patient's ability to both experience and reflect on their feelings. This is also important. Cluster B personality disorder are very much unaware of what they are feeling. Okay, they act on a very superficial level. So you have to make them aware of their own feelings, and with awareness of one's own feelings comes the awareness of somebody else's feelings, and that is called empathy. Empathy is lacking in cluster B, right? So making them aware of those feelings is also one of the important parts of the therapy. So this is a brief overview of cluster B PD in general. They are characterized dramatic, emotional, or erratic. Empathy for others, albeit for different reasons. Okay, what are the reasons? Narcissistic personality disorder do not see others as important enough to warrant empathy. I am holding so. I don't think others deserve empathy. Okay. Borderline personality disorder find themselves too much of a victim to have any empathy to share. All their empathy is for themselves. I have this problem. Everybody is doing injustice to me. People are leaving me. Okay, so they are always the victim. And antisocial personality disorder cannot even conceptualize empathy. They actually do not have it. Okay. So now we'll come to our main topic. It is antisocial personality disorder. So what happens in this? There is wanton disregard for and violation of the rights of others. They do not care about the rights of others. Okay. Have you seen the Hannibal movie? Dekha na? Silence of the Lambs dekha? Have you seen? If you have not seen it, you must watch it because it is a movie. I mean, Anthony Hopkins got the Oscar for that. It is a very good movie. Even it is an old movie, but it is relevant. Even today also, you will enjoy it. Okay. So the main character in Silence of the Lambs, that is Anthony Hopkins Hannibal, he actually embodies antisocial personality. So there are some narcissistic factors, no doubt. But if you want to see something, to really understand that character has antisocial personality disorder. Okay. So they feel any sense of entitlement is also an entity, but also an antisocial. I feel rules are not for me; they are for lesser beings. Okay, rules are not for me. I don't care about the rights of others. This is what they are thinking. Very overdeveloped combativeness. They will fight at even small matters, they will fight. Exploitativeness. They will exploit others, okay, manipulate others. Especially antisocial personality disorders who have high IQ. Okay, they are very good at manipulating and exploiting other people. And predation. Okay, you know what is predation, like hunting kind of thing. Okay. At the expense of empathy, reciprocity, and social sensitivity. Okay, they lack these things. Repeated criminal offenses, manipulation and mistreatment of others for personal gain, amusement, or in the throes of passion, and little or no remorse for misdeeds. We'll see, like there are two kinds of ways we'll go further, but they do these things and they have no remorse. Okay. So this is the diagnostic criteria according to DSM-5 and accompanied by subjective distress, or subjective distress is not very common, but functional impairment. Subjective distress might happen when they are caught, okay, not because of their behavior, or functional impairment. Antisocial PD is the appropriate diagnosis when a person is at least 18 years of age and there is evidence of conduct disorder with onset before 15 years of age. So this is important. This is not there in other personality disorder. This is something for antisocial, okay? There should be evidence of conduct. Like I said, suddenly you do not develop overnight, PT does not develop. Okay, so there is some evidence of conduct disorder with onset before 15 years. Okay, and at least 3 of the following. Okay, these symptoms are pervasive. Obviously, 3 of the following. 7. Unlawful behavior, deceitfulness, impulsivity, assault, reckless disregard for the safety of self or others, consistent irresponsibility, and lack of remorse. Deceitfulness is reported to have the higher predictive value for an accurate diagnosis. Okay? Means they will manipulate, exploit, and use others without any remorse and without any guilt. Okay? Because they're deceitful, early diagnosis is very difficult because they will try to deceive you also. They will not give appropriate therapy. They will always try to police police problem. They will try to play victim that because of maybe social or racial profile, police arrested you, all those kind of things. So you have to have collateral information. Because only if you talk to the patient, you have an idea that patient might be trying to deceive you, but you will not know for sure. Okay? The impulsiveness of the antisocial patient may emerge in social or occupational dysfunction or in suicidal or homicidal behavior. Okay? So we have to obviously have a differential diagnosis. Intermittent explosive disorder. Intermittent explosive disorder, the patient has feeling of remorse. There is only intermittent explosions, intermittent anger outburst, and the patient later will have remorse for that. Okay. And the grandiosity, impulsivity of bipolar disorder. Bipolar disorder is episodic. Okay. And there will be clear-cut onset. Okay. So, or the aggressiveness and recklessness associated with substance use. Sometimes it is very difficult to differentiate because the comorbidity is very high. So we need history. Was there conduct disorder before 15 years of age? Was there this kind of behavior even before substance use started? Okay, so collateral information for all PDs, collateral information from relatives, especially parents or people who know the patient from childhood or early adolescence is very much necessary. And if we can have from school and schoolmates, school friends, that is even better. But mostly that's not possible. With parents, it is absolutely necessary. That's why I say that when you take the history, don't give a diagnosis of PD, say traits, because we are mostly not talking to the parents in all cases. So comorbidity, they are more likely to have a comorbid excess 1 disorder, including major depression, that is around 30%, bipolar illness, panic disorder, PTSD, ADHD, or substance use disorder and comorbidity is 80%. Like I said, that's why diagnosis becomes difficult sometimes. And 5 to 10% of antisocial patients are at a lifetime risk of suicide. Nearly 1/3 of suicide victims carry a personality disorder diagnosis, and that antisocial personality disorder is common among this group. So these are the predisposing. We do not know for sure why personality disorders happen. This is both nurture and nature, genetic and social factors. But obviously these are heritable, so there is a part of genetic, and these are just associated factors, we can say. XY chromosome, and we have seen some physiological characteristics like low resting heart rate. Because of this low resting heart rate, when they do this antisocial activities and all, they do not have those kind of panic and anxiety that normal people have. So that's why it is mostly associated with it. Okay, higher plasma testosterone, limbic stimulation, or neurological soft signs are there, like EG patterns, certain EG patterns, impaired ability to concentrate, and motor and hand-eye coordination. These are very non-specific. Okay, like these may be associated with many people, but all do not have antisocial personality disorder. But this has been seen to be associated. So what are the socio-cultural factors? Male gender, having low socioeconomic status, a difficult temperament in infancy, antisocial parents, stress, living in a high crime neighborhood, and having unskilled grandparents, family discord, divorce, parental rejection and negativity, and modeling of antisocial behavior. Again, these are just associated factors. So the course is they will have poor academic performance, mostly. Okay, there will be peer rejection, or they will have peers who are themselves antisocial, because obviously who will be your friend if you are manipulating, exploiting people, having no empathy, having no kindness. And later there will be substance use. This evidence suggests that symptoms may decrease or burn out after age 40. In a sense, maybe with age, everybody gets a certain amount of maturity and calmness. Okay, it's not that they might develop empathy. It is not like that, but the antisocial activities themselves per se will decrease because of certain level of maybe testosterone levels are decreased, or with age all of us become calmer. We are not the same that we were in our 20s or teens, so that's why. But it's not that after 40 they will develop empathy. It's not like that. Okay? The course of antisocial personality disorder, however, is generally regarded as unremitting because the core features are always there. Okay. So what is the treatment? Early intervention during childhood and adolescence is desirable. Yes, because by the time the patient, if you treat them later, they are very set in their ways. Okay. Early treatment might help them realize how their actions are affecting others. Okay. So early treatment is always desirable, also because early treatment can make them more adjusted to society. Later, if you go, they will have criminal record, they will have poor academic performance, so it is difficult to make them adjust. Okay, but it depends on the patient's willingness. You cannot give somebody psychotherapy against their wish. Okay, and that is where cluster B, it is difficult to treat, even A, because patient is very egocentric. Okay, the symptoms are maybe in some borderline, it sometimes might not be, but in narcissistic and antisocial, they are very egocentric. They do not think they have any sickness or they require any treatment. So it depends on the patient's willingness to participate. And this is made more difficult by the egocentric nature of the symptoms and the antisocial patient's intense mistrust of others. Why does intense mistrust? Because at some level, they are themselves not trustworthy, okay? They manipulate people, they exploit people, they use people. So they think, they perceive that is how everyone is. They do not realize that this is something that only I have, and generally people are not like that. So that's why they don't trust people, okay? And when they don't trust the therapist, there is rapport is difficult to establish. And because it is egocentric, they do not seek treatment normally. Sometimes they go to jail or the family members drag them to the doctor, that is different. But normally, how many patients have you seen come in and say, Doctor, I have antisocial traits, please treat me? Nobody will say, I have not seen till date. So how do we treat them? Positive reinforcement, okay? Whatever positive activities we're doing, we have to reinforce that. Reality-based approach, concrete interventions, okay? If the person is repeatedly committing some crime and going to jail, then we have to concretely say, ki, make the situation such that the person does not have to repeat the crime. Okay, so concretely, you cannot really go into dynamic thing or concrete real life steps. An education oriented anger management or impulse control program and other cognitive behavioral techniques. So you have to focus on the specific issues that lead the patient to therapy. Sometimes patient come into therapy because maybe the jail prescribed or jail sent him to a psychiatrist, or the relative somehow dragged him, or something happened. So whatever issue he is coming with, you have to address that. And sometimes patient come for depression. Antisocial people also have depression, like we saw. So sometimes they'll come for depression, or sometimes they'll come for substance use. So first you have to see the specific thing for which they have come. Okay. Focus on the reality of patient's life situation and de-emphasize the relationship with the therapist. This is very important. Don't get entangled with them. Okay. You have to manage your counter transference, and you have to be aware of their transference. Okay. Because they will try to drag you into their drama too. Okay. An initial focus of treatment might be the patient's aggressive behavior. Using CBT, the patient may be asked to consider what might motivate or reinforce such behavior, why they are being aggressive. Okay. For example, the use of aggression to create safety for themselves, to relieve tension, or as a defense against others. Like I said, they don't feel things. Okay, the real emotions. So aggression might be easier way out for them. So you have to focus on aggression. Like, why are you becoming angry? Because you feel unsafe, or you feel injustice has been done to you, or you do not want to feel sad or rejected. That's why you are angry. Okay. The patient's awareness of their primary defense mechanism, in this case acting out, is believed to constitute a major breakthrough in treatment. So the patient has to understand that the way the acting out is not healthy and it is not helping him achieve. Like suppose the patient likes a girl and he wants to be in a romantic relationship with a girl, but the girl is rejecting and he is becoming violent and acting out and harassing. So just to understand, this is pushing others even more far away. Okay. So they have to understand that my defense mechanism is very immature. And then you have to change, pros and cons of changing their behavior. If you change your behavior, if you behave nicely, maybe people will be attracted to you. I'm just giving an example. If you're nice, maybe your boss will like you, your colleagues will like you. So you have to give them, the alternative. If you are better behave, what are the changes that will come in your life? You have to always talk like, unka kaisa fayda hoga? Okay? You cannot say, if you change, others will feel relief. They don't want to change. They don't care about others. So you have to say, if you change, your life will become better. So it is always about them, you. Okay. Patient learns to identify trigger signs and interval. Something is happening that is triggering me. Okay. Anything, there might be rejection, okay, or might be somebody is not doing according to their wants or their instructions. So patient with therapy will realize that this is what will trigger me now. So I should kind of move away from this situation, or direct pent up anger at inanimate objects, or employ relaxation techniques, or learning to walk away from arguments before it escalates into physical fights. Okay, cathartic physical exercise, like if you have like too much energy, do exercise. Okay, don't go and involve in a fight or complain to a third party like the doctor, neutral third party. Okay. Also, the other kind of therapy is focus and understand the consequences of their drinking, okay, or drug use. What are the consequences, how it is harming your life, and understand how others are affected by their behaviors is also been shown to be effective. This comes later in the therapy. After the patient realizes how the kind of his behavior is affecting him, then you can say ki also it is affecting others. Others means you have to see who the patient is close to and care something about. Sometimes patient may have a parent figure or a brother or sibling or some friend, someone who is actually a bit close to them. Okay, so you can see how your behavior is affecting that person. Empathy training can be successful in reducing recidivism. Recidivism is repeated, like offender repeat offense. Okay, well, a person going to jail, repeatedly going to jail is recidivism. So empathy training has been shown to reduce recidivism, but if you do empathy training, these people are unaware of how others feel. Okay, once you do empathy training, they will learn now how others feel, and they might use that to manipulate others. this is a big dilemma, okay? Because these people will then do acting of empathy and try to manipulate others. So this is a double-edged sword, okay? And boundaries and limit setting is essential. Okay? Also, group treatment. Cluster B is difficult to treat. We all know that. Narcissistic or antisocial PD may challenge the leader for control of the group. If you try to take a group therapy, they will challenge you only. Okay. They will try to, not follow instructions. They will try to insult you in front of others. This kind of things. And what do borderline PD do? They may try to incite the group to save them. Like this therapy is harming us, we are victims, and the doctor is treating us. Instead, the doctor should go and treat others who are harassing us. So group therapy is difficult because handling one cluster B is itself a big task, and to handle 3-4 are sitting, and then it is very difficult. Okay. So group psychotherapy, but group psychotherapy offers a unique opportunity for community autonomy, intimacy, individuation, and a setting in which to learn about relationship that is tempered by appropriate limits. But group therapy is the advantage that in group therapy they can learn interaction. Okay. And how to be in a group, how to talk in a group. These are the things they can learn. So certain specific group therapy can be done, like role identification. Role identification, we know that you become a certain role, and then the patient is certain, and then you interact, and then you change the role. You see how you are feeling. So that kind of thing can be done. Or cluster B patients can begin to understand how their interpersonal world and their individual symptoms mutually affect one another. Like we can see one patient and two mother. So see, act it out, like how you will behave. Then the patient who has become the mother, he might realize how the patient is behaving is affecting me. Okay, so that is what is called as role identification. Also, what are things to consider for before group therapy is, will the patient likely commit to the group? Will the patient be able to follow group rules? Can the patient manage their impulses and appropriately interact with others? Might the patient better served in a homogeneous group? Homogeneous group is if one diagnosis, like antisocial PD, all antisocial. Antisocial, the very deadly combination is narcissistic and borderline. Okay, they mostly have so much entanglement with each other that it is very difficult to have group therapy with such patients. And obviously, any bipolar or schizophrenia kind of rules out group therapy. Okay? Active schizophrenia or active bipolar. Given the group's composition, can the therapist manage the emotions? Can the group handle the role the patient is likely to play? And does the age, gender, race, and level of ego development of the patient fit the group? Regardless of whether or not a cluster B patient is appropriate for group therapy, concurrent individual therapy is advised. The group therapy is not a substitution. Individual therapy is always necessary. Group therapy might be in addition to that. Antisocial patient is generally not involved in group therapy, except they may initially be an active and important group member, but then they will try later to manipulate. Okay. The characteristic manner of relating will place them in an interpersonal role that will likely be destructive to the group and therapeutically contraindicated to themselves. Because I again try to manipulate and prey on others. So what is the point of therapy? You are just providing them with prey. Okay, they are predator. You are providing them with prey. But specialized forms of group therapy can be there, like family and marital therapy. These people have family discord. These people have marital problems. So such type of therapy can be done with their family members. Also, the patient relationship with significant others is a stronger motivator for change than is the relationship with the therapist. Sometimes, as I said, there may be one person who is close to them, maybe a spouse or a parent. So that can motivate them better now. Why will they try to change for you? At least they will try to change for that person. And the patient is more likely to accept confrontation from them. If you confront them, they will become very defensive. But if the person to whom at least they are somewhat close, confrontation from them is acceptable. And also, family members can also learn how to better use assertiveness for their own protection. Family members of antisocial PD, generally, this PD increases because the family members accommodate it. Okay, they will try to accommodate it. They will try to make excuses for it. Okay, he has so much stress in his life, that is why he is behaving like that. Everybody has stress. That is no excuse. No, so the patient family also needs therapy, and they have to be assertive. Even if you have therapy, even if you have stress, that is no excuse to act out. Okay, assertiveness is very important for family members. Milieu and residential therapy programs can be there, such as token economy. You know what is token economy, right? Token is given for good behavior, and you can exchange the token for some benefit. Okay. Therapeutic community is also there. Therapeutic communities, like patient can see the flaw in others that they have in themselves. Okay, so they might have some insight. They may be more likely than therapists to confront other patients. They will also confront if you are doing this, so I am having problem. Okay, they will confront other patient, other antisocial. One antisocial patient will confront another antisocial patient, and another patient might be more receptive to their confrontation than from the therapist, because they are like, therapist is not from their group. Okay, therapist is an outsider for them, but if they're in a group, they might be more amenable to confrontation for each other, and with confrontation comes some degree of insight. Okay, and you have to diffuse the intense feelings often developed in the individual therapy relationship. Who has to diffuse? The therapist has to diffuse. Okay, therapeutic communities may be effective because they utilize a psychoeducational model of treatment that tends to elicit less disturbing effect in patients than does the intimate examination of intrapsychic and interpersonal issues typical of an intensive small group therapy. In small group therapy, we try to go into the whys. Okay, why this is happening, why you are feeling like this. Sometimes that may become too intense for the antisocial personality person. Okay, but therapeutic communities more focuses on the behavior. You do not act this way. It doesn't matter why, or it doesn't matter what you are feeling inside. You cannot act out, irrespective of what you are feeling. But in small groups, we are like, why you are feeling this anger? What is there behind this anger? Is there sadness? Is there feeling of rejection? If you go into deep like that, there may be some resistance. Okay, there is severe resistance, and there may be transference and countertransference. Okay. Prognosis is improved with medication, beta blockers, neuroleptics. We know this, SSRIs, antipsychotics, and so Depo-Provera has been used for sexually violent offenders in US. Okay. So there are two kinds of aggression. One is affective aggression, that is laden with significant emotional arousal. Okay, and another is predatory, like you have seen in many movies, and serial killers are there. They have no emotions. Okay, which is devoid of affective arousal. Their pulse rate is not increased. Their heart rate is not increased. They are completely cut off from what they are doing. But affective arousal is more or less how we get anger. Okay. Fluoxetine, like certain agonists like fluoxetine and anticonvulsants have been found to inhibit both types of aggression. Fluoxetine also decreases mood swings and impulsiveness, but benzodiazepines have been found to inhibit affective aggression. Okay, but there is a concern that they abuse benzodiazepines. They take them or they sell them. For some patients, benzodiazepines have been shown to have a paradoxical disinhibiting effect. We know this. Benzodiazepines, paradoxical disinhibition, it happens, right? So crux thing is, don't give benzodiazepines. Try to avoid. Okay, give as less as possible for as short duration as possible. That applies to everybody actually, not for this people. But this is also true for antisocial. Okay, so these are my references. Any questions? आप लोगों को समझ में आया? थोड़ा मतलब पीडी थोड़ा पीजी लेवल है, but I think you have कुछ तो आइडिया आ गया होगा आपको. I think we have to share about any patient case scenario recently you saw or anything. हमारी ओपीडी में तो बहुत फर्क है. Yes, sir. And in substance abuse also, I've seen like every substance abuse person is not a PD. There are some specific people they will try to manipulate. Like you write the medicine, then they will go down, and then they will go to another doctor. They will get it written. Also, they will come back. Like this is what patient came. He took the medicine from this ED room, and then he later came and said he was not giving me the medicine at all. And the person downstairs he took more money than than it is written on the bill. So these kind of scenarios they create. This is the pakka antisocial video. They're trying to manipulate, but many patients they are very how do I say, very normal people. So buprenorphine population also you have to see, like don't give more than medicine to such antisocial patients, because more likely they are going to sell it to other people. Some people generally come from those hills and mountains and all. I give a message, they cannot come. But especially in government hospitals where I was working before, they used to come with guns and pistols and knives. They were like, they were getting the medicine free of cost. Okay, so they had no regard for the value of the medicine, and used to come and threaten the nurse for giving them medicine. And but it was under NACO, so there was nothing much we could do except keep a security guard. But what will the security guard do? He only has a stick and he's coming with knives and all. So this is a very challenging situation, especially in government hospitals.
Dr. Smriti, very good presentation. I just have to comment this antisocial, dissocial personality disorder was also thought for some time, because if you think of it as a disorder where the individual is not, responsible for what is happening. So they thought that like a person can adapt. So specifically for traits if the person has. So these people are more likely to go into armed forces, police. That is a paradox that antisocial personality disorder they opt more for police enforcement because they want to, kill other people or you can say enforce. They don't have that much empathy. That draws them towards these professions also. And there are studies that show that CEOs specifically they have antisocial and narcissistic traits. Disorder they might not have. And you can think that if somebody is moving from one place to another, so he's very sad, like what will my driver do, what will my maid do? And these people are firing 100 people in a day without thinking like where will they go? They are working with people in a team and they will fire half their team with whom they have worked. So they have these traits, antisocial, dissocial traits where they have this lack of, you can say not lack of empathy, but they can very well overcome empathy in these routine, you can say, decisions for business and politics. You can see that they are pitching so quickly, they are pitching partners, and so traits are there, but person disorders are there. In prison, you will find like if there are also studies that most of the prisoners will have antisocial personality disorder, again some may not. It is not also like if somebody is committing crime that he will have personality disorder.
So it all depends a lot on your IQ, your family support, the kind of money your parents have. Okay, like this narcissistic people who rise to the top, they have good IQ. Okay, they're intelligent and they use that. They try to limit the crimes and they use it in other ways. People who mostly end up in jail, they do not have good family support. I mean, the low socioeconomic status and also not so much bright and intelligent. Okay. There is a very, as I said, I also have downloaded a paper. I will discuss it in narcissistic PD, how narcissistic PD have in top positions. I'll discuss that there. Okay, thank you.
Also, suicidality is relatively higher in them. No. They are prone to, so it is a paradox that antisocial personality disorders, they are like in height of impulse, they can also commit suicide. That is also that.
Yes, mostly maybe intoxicated or sudden anger outburst. Impulsively, they don't actually plan it in the way depressed patient does, but it is more kind of an
suicide by cop. They will go fight, shoot with the police so that they want death by cop. That is it's like they will shoot me. So
there is a series that I'm watching now, Dahmer on Netflix. If you have time, do watch it. I mean, it is a serial killer, and the way he dissociated from his emotions. He's a very good actor actually who has portrayed it. But the dissociation from emotions is very nicely portrayed. Some things are very educational, like especially for psychiatrists. So, अगर आपको देखना हो तो देखिए.
There is a family also. Is there any system changes and a single parent family? When the mother has more than one child.
Yes, neglect. Yes.
It is a reason for the.
Yes.
And there is correction systems also. There is a journal system. The journalist also has more.
Yes.
Prone to antisocial
antisocial activities. In fact, they have gone to juvenile facility because of some antisocial things they have done. So that is it. Thank you, sir. Thank you. Thank you. यहाँ पे एक माउस कार्ड रख दो ना. प्रॉब्लम है. अच्छा पीपीटी बंद कर. हाँ बच्चे.
हेलो.
कबीर सिंह हम देखिए कबीर सिंह होगा वो पीढ़ी तो है.